non-private practice, you can have your appointment for 3 or 6 months.
Wow.
What we try to do to like diminish that burden between patients who can afford for a private consultation or the patients who don't, if we have a free clinic on Saturdays,
Okay.
and we try to mitigate that impact. We having that free clinic, I can tell you 126 patients with MS
Wow.
treating, and they can get they can visit us every Saturday they want. We all have space. So in Bogota, we're trying to mitigate that impact, but I know that in other regions in Colombia, they don't have this kind of support, and probably there are not a lot of neurologists in other regions of Colombia. So we have to ask for consultations in Bogota, Medellin, or Cali, which are the biggest cities.
Understood. Okay. And then another question I have. So, have you ever experienced an issue where the insurance plan runs out of stock of the medication when you prescribe a certain medication? And if so, what happens?
Fortunately, it's never happened.
It hasn't happened to you? Okay. Understood. Great. Perfect. Well, I think we'll go ahead and pass on to the profile of Product X. So just before we pass on to some of the data, I wanted to contextualize the product as it's a little interesting. So it has a peculiar pathology. There are only 20 doses in the first 2 years, as you can see from the pills on the screen here. But product can offer efficacy for up to 4 years. So you only need to take the medication for the first 2 years, and it offers an efficacy lasting in the years 3 and 4. I'll caveat that not all patients arrive, without a relapse in year 4. It's about 70%, but it does have a peculiar pathology in this way. So I'll pass on now to some of the data points that we wanted to show you for Product X. I'll give you a couple of minutes to take a look, and then we can review. Just let me know when you're ready.
Okay.
Perfect. Okay, so I guess to begin, what are your general impressions of Product X, and what would you consider to be some of the strengths of the product?
Well, my first impression is that I don't really understand very well its mechanism of action.
Okay.
So I don't know if it's an antibody targeting lymphocytes, or what's its mechanism of action.
Okay.
So that's the first one. The second one is why did patients of this cohort receiving Product X have more patients in T2 and not in T1? Like, I understand that T1 is going to show that's contrast enhanced. Do you refer to that?
Can you repeat that question again? Sorry.
With T1, do you refer to contrast enhanced MRI for mean number of lesions per patient per scan? So my question was, if you're not very sure about that, what I'm trying to give you the idea is that with T1, if it's contrast enhanced MRI, it means that the disease is active. But with T2, we are seeing lesions that are there, but we cannot identify which ones are active or which ones are not active. So
understood. I think both. I'm sorry. I think both T1 and T2 are active.
Okay. And the other one is what were the reasons for patients to die with this product?
Yeah, so I think one had to do. I think one was related to suicide, and I think the other. I can't remember the other cause at the moment, but I don't think they were necessarily related to any adverse events experienced by Product X. Okay,
so the strengths obviously are first the dosification regime, which is very comfortable for patients, and I think it's not going to be very problematic in our system.
Okay.
And the adverse events are very tolerable for patients. If they have headache, probably we can treat it. And lymphopenia is an adverse event that is related with every medication in MS is expected. So I think it's not going to be very harmful for patients.
Understood. Okay. And I guess as you can see, and as I showed you in the previous screen, the pathology of product X is could be perceived as convenient, given that it's only administered, in doses and it's oral. So, how, I guess, would this characteristic of product X factor into your prescription habits?
So for us, it's very useful because most of our patients prefer oral medications.
Mm-hmm.
So it's going to be in our package of medications that we will want to prescribe. But we're balancing what medications we are going to choose. It's not going to be because of that, because oral medications, like for example, the others are taken every day, only one time or twice. Mm-hmm. So patients can they can get used to those.
Understood.
So the most important thing that we're going to take into account or consider to choose between one medication or the other are going to be the adverse effects or its efficacy.
Understood. Okay. And then are there any weaknesses that you find in the profile that we've shown you?
I don't think there are weaknesses. I have a comment that I have since I filled the form.
Uh-huh.
I don't know if you want me to tell you that now.
Uh-huh.
Yeah, it's like it was compared with ocrelizumab, and ocrelizumab in our country is only authorized for primary progressive MS. So if this medication is going to be approved for RRMS, probably be better that you don't compare those, because it's not like neurologists are going to ask you the same question here.
Understood. Okay. Great. Well, I think now we can go ahead and move on. So we wanted to test, I guess, the profile of product X in several lines of therapy, as it has data for patients both in low disease activity as well as high disease activity. So moving on to a comparative slide here, we've stacked up various data points of product X relative to traditional platforms such as interferon, glutamate acetate, teriflunomide. So, I'll give you a second to review, but when you're ready, it would be great if you could walk me through your general perception of product X in this line of therapy.
Okay.
Perfect. So again, what are your general perceptions of the product relative to these other medications, and what would you find to be, if you had to choose, the most appropriate comparator for product X in this line of therapy?
Okay, so my general perception is that product X is more he has more efficacy, safety, tolerability than other medications. You're comparing it with another oral medication that it's a very good option, but as I told you, teriflunomide, we use it for second line therapies probably, and interferon beta 1A and glutamate acetate, we use it for a first line therapy. So probably comparing product X with teriflunomide could cause us a conflict, because probably product X can be given earlier for patients who also have a low disease burden, not necessarily very aggressive MS. The other thing is that just because for the way you presented the data, in the statistics showing patients remaining relapse-free at month 24, it wasn't very clear for me at the beginning that 60.9% referred to placebo. So it would be
apologies. Yes.
If you put that there.
Okay.
And the other thing is that lymphopenia, I understand that grade 4, it's an indication for stopping the treatment with this medication. So it says that most patients recover to normal lymphocyte counts, but they stop the medication, or what happened?
This would be So I think that